welcome to a brand new episode of Seize the Moment podcast. Today we have a very special guest. We have Troyen Brennan. He's an adjunct professor of health policy and management at the Harvard T.H. Chan School of Public Health, a former professor of medicine at Harvard Medical School, and the former chief medical officer at CVS Health. He's the author of The Transformation of American Health Insurance on the Path to Medicare for All and Just Doctoring, Medical Ethics in the Liberal State. And his new book, available October 7th, is called Wonderful and Broken, The Complex Reality of Primary Care in the United States. Troy, it's such a pleasure to have you on, and thank you for being with us today.
Thank you for having me.
Absolutely.
Absolutely. And so in his book, Troy wrote, fee-for-service reimbursement in itself is not bad. The problem is the incentives it creates when the fee-for-service determines clinician compensation. The financial signal is to see lots of people and see them fast, not tarrying to deal with their problems. In a foundational article from 2001, economist James Robinson correctly pointed out that fee-for-service, capitation, and salary all have potentially negative incentives if the goal is better health. But prospective payment fits most neatly with an incentive for promoting health and preventing illness, emphasizing value-based care. That is the critical assumption of this book and much of what one sees in cutting-edge primary care today. Most primary care today remains mired in fee-for-service incentives. As a result, many primary care physicians believe they are underpaid and underappreciated, and as a group, they border on despondence. Burnout is rampant. Okay, so Troy, before we get into some of the details of this and how it affects specific people, so I know myself, so I'm in the sort of healthcare industry, and so as somebody who works with insurance companies, et cetera, and I find myself struggling with a lot of what sort of the meanings of these terms are, what these systems are, the differences between these systems. So can we actually get into the basics, like what is sort of fee for service, what is value-based care? How would you even differentiate between these?
Well, they're pretty easily differentiated. Fee for service is retrospective payment. I do something, I send in a bill, I get paid for it. So it
Mhm.
makes good sense for like a surgeon. I do a operation, I put together a bill, I send it to the insurance company that pays me. They're used to getting paid on a piece. Unfortunately, that's the way primary care is paid by and large in the United States as well. So instead of like a surgical procedure, it's an evaluation and management code. You go in and see your primary care doctor, you have a experience with them. They basically grade that at a level 0 to 5, and it called an evaluation and management code. And then they send in a bill depending on sort of how long they took and how complex the patient was to the individual insurance company. So, as I said in that quote that you had, what that does is it sort of sets up primary care doctors. If they want to maximize income, they got to see lots of patients. And they're not necessarily sort of thinking, I'm going to be able to take care of everything for every patient when they come through, because I've got to manage about seeing people about every 20 minutes or something like that. So, value based, on the other hand, is also related to managed care, prospective payment, capitation. You get paid to take care of an individual for a period of time, and it doesn't matter how many times you see them. You're not billing for individual codes like that. Instead, you're being paid sort of on a subscription fee. So,
Hmm.
the way that a doctor put it, I'll go on just a little bit. The way that one doctor put it, who I thought was very insightful, young doctor, North Texas, just setting up his practice. He was involved with a group called Catalyst, which is an independent practice association that's trying to get people into sort of prospective payment. He said, my dad was a doctor, and the only ways in which you got a hold of him was either on the telephone or in his office. So paying of a piece made sense. Now I'm basically got pharmacists, care managers, nurses who are taking care of the patients. The patients are talking to me on the portal that's associated with the electronic medical record.
Mhm.
I'm talking to a lot of consultants about the individual patient. So, getting paid on a piece no longer makes any sense. I have like 25 different sources of information coming in. Getting paid on a subscription basis like Netflix is much more sensible. And that's really the difference between a sort of value-based approach, paid prospectively to take care of this person over a period of time, as opposed to retrospectively sort of billing every time I see the patient.
Hmm.
Interesting. So that actually, so I happen to, I can't reveal which company I work for, but I happen to work for an insurance company, and something I used to do there is that I was in a provider service department, so I would be receiving claims essentially and seeing how they're paid out, that sort of thing, allowed amounts and such. One interesting thing that I noticed is whenever I noticed, let's say, capitated doctors receiving their checks for having, let's say, a patient or set of patients for, let's say, 30 days at least, for a particular month, I would see how much they're paid. Funny enough, I noticed that even if, let's say, a doctor had, and I might be a little bit wrong because this has been some time, but even if a doctor, I think, had, let's say, over 1,000 patients, compared to how much they were being paid or how other doctors were being paid per claim, depending on what codes they were billing for, I noticed they actually weren't making that much through capitation. Like yes, it was like thousands of dollars for sure, but compared to, I guess, how much you could make at least currently, seeing, I guess, yeah, a patient every 10 to 20 minutes and filling up your days like that. It is interesting to see the difference in the value in the incentive for the doctor to be capitated versus not capitated, at least at this moment in time.
Right, right, right. And there's different forms of capitation. Some are just a fraction of the overall cost of the patient, so-called primary care capitation, where they pay you an estimated amount for the various visits that you would see a patient for over a period of time. In other circumstances, many practices take full capitation. So they're responsible basically for everything that's going to go on for that individual patient. And they have to be careful to try to keep the patients healthy, promote their health, make sure they get all their preventive services, keep them out of the hospital. If they get out of the hospital, make sure they don't go back in the hospital. So they're looking at the entire picture of a person's health, as opposed to a fee-for-service situation where basically it doesn't make any difference if the patient goes in the hospital. And in some ways, if patients in a hospital, at least they're not sort of adding to the list of patients I have to see in a given day. So the prospective approach has much more of an association with promoting health, whereas the retrospective approach is just basically I'm trying to sort of put my fingers in the dam as they come through.
Mm.
Yeah.
And I can see how this would be like a win-win for the doctors and their patients too, because one, doctors would definitely experience less burnout, right? That's one, because you're not trying to just see as many patients as possible. Also, from the patient's perspective as well, you're not coming to an office where, let's say, there's 30 people. I mean, I've seen this before, 20, 30, even 40 people sometimes in the waiting room. They have an appointment. Let's say it's 10 a.m. They're there at 10 a.m. But for whatever reason, they don't even see the doctor right away
Mm.
because the doctor's just trying to grab as many patients as possible, walk-ins and such. And so I could imagine, yeah, in a sort of a value-based sort of approach, uh, maybe there'd be less of that, right? Like from the patient's perspective as well. Like they might not necessarily um, be waiting so long to see the doctor as well, or they might even have more time with their doctor.
They
Uh,
definitely do. And
yeah.
in the practices that are working well, taking prospective payment, the patients get much more time. I'm acutely aware of who my sickest patients are, and I want to
Mhm.
be seeing them frequently. And I'm less burned out. The burning out situation in fee-for-service primary care is absolutely horrible. I talked to
Yeah.
one doctor who had been sort of 7 years in a practice in Kentucky somewhere where he was fee for service. And he said, I'd see 20, 25 people a day, and I just couldn't keep up.
Mm.
He
Mhm.
moved to Kaiser Permanente, which is a value-based approach. And he sees much sicker patients, but he only sees 10 to 12 patients a day. And he feels
Mhm.
like he has a supportive team around him that's also providing care. And that's important to emphasize is that when you do get paid prospectively, you can develop the team you need to be able to take care of the patients. In a fee-for-service approach, it's really difficult to get those patients, those additional team members paid for. They can't really submit the kinds of codes that are going to get reimbursement from the insurance company. So, if, for instance, I got somebody who's on a very complicated regimen and I need to get that regimen simplified, regimen of medications. I need to get that simplified so they understand when and where they have to take their medications.
Hmm.
I consult a pharmacist, so there's pharmacists in this value-based practice, and they can do a full consultation and help get the patient on a much more simplified regimen.
Mm.
That's not available in fee-for-service.
Hmm.
Oh wow. Yeah. Yeah, and so I can really mostly speak about it from a psychotherapeutic perspective because I am a psychotherapist. So I remember when I first started out and I initially worked for a clinic, the sort of it was a pretty significant business model. So we're oriented toward a pretty significant business model. So I remember the idea was that instead of sort of scheduling patients consecutively, the way that people were scheduled was essentially they would take open slots. So meaning there wasn't really much of a system in place. So let's say hypothetically a patient were let's say a weekly patient. And then they would come in and they, let's say, spoke to the receptionist and they would say something like, hey, I'd like to come in next week because we agreed on a weekly timetable, etc. A lot of times those sessions wouldn't be open because there are new patients and there's an influx, again, fee for service. So I guess I wonder if, like, and of course, this is a pretty specific field, but I'm just wondering, broadly, if we can answer this question. What would it look like from a value based approach if we weren't doing this, right? So if we weren't focused on or having actually long wait times, right? If there weren't problems with scheduling, right? Like how essentially can we navigate that from this particular approach?
I mean, how do we go about sort of getting there from where we
Yeah.
are today?
Yeah, from where we are
Yeah.
today.
Well, a lot of practices are doing it, and that's the whole point of the book. I went out and talked to a lot of value-based practice. I talked to some that were fee for service, but they were very much the same. So I didn't have to sort of constantly sort of visit repetitively fee for service practices because the stresses and the burnout and the issues were very similar from practice to practice. But on the value-based side, there are very big practices today that are completely value-based. The Kaiser Permanente system, for example, most of the Optum system. Optum is now the biggest employer of physicians in the country.
Mm,
Humana has probably somewhere between 400 and 500 clinics that they operate. And then there's a lot of different kinds of places where startups are getting involved and trying to convert fee-for-service practices into value-based practices. I visited a practice in Manhattan, Kansas, for example, which you don't usually sort of think of as being on the sort of cutting edge of health policy. And there was a practice there, the big practice in town, had decided that the future just could not be fee for service. It had to be value based.
Hmm.
And so they had contracted with a company called Aledade, which helps them set up their data, do their negotiations with the insurers so they can get value-based payments, helps them set up a team, provides the information for the team. So it's kind of an architecture that includes sort of expertise as well as data analytics. In many ways, people say it's similar to the old agricultural services that the federal government used to use to sort of advise farmers about how to improve their yields, the so-called Farm Bureau.
mm,
But working with this company, Aledade, these kinds of practices are changing over, especially with regard to their Medicare patients, to much more of a sort of prospective and value-based approach. So there's a lot of learning going on out there and a lot of sort of slow conversion towards value-based. If you talk to most physicians, and most administrators, I think value-based is the only way we can go forward because the fee-for-service system just seems to be nothing but sort of higher costs and poorer care.
right, right. And just again, kind of going back to what I was saying before. So the thinking was, as I'm sure you can imagine. So the thinking essentially was let's schedule as many patients as possible because fundamentally we can't really trust that a lot of these people will come in weekly, which to some extent I do understand. But the idea was let's kind of book you out and let's schedule as many patients as possible so that we could predict how much money we're going to make, etc. Right. But then fundamentally what would happen is people essentially would actually drop out. So interestingly enough, this fee for service model actually probably caused more dropouts than bringing in people because what would happen is even though they'd agree to coming in by let's say weekly or even bi-weekly, they wouldn't be able to get the appointment. So I remember somebody saying at one time, they said the reason why I didn't come back is because like there's no consistency. Even though we agreed on weekly sessions, the way this clinic structured doesn't structure the sessions doesn't feel like it makes sense. So it's so interesting because I guess I wonder from your perspective, Troy, why do you feel like it's been so hard for us to move away from this system when it's honestly in some ways even bad for business as well?
Well, it works pretty well for the well off, that is,
Mm,
for specialists and for hospitals. And, they have not been interested in trying to sort of manage care and reduce costs by more careful attention to individuals. If you think about it, if you're running a hospital, and this hasn't changed since I was in public health school nearly sort of 50 years ago. The
Mhm.
business model is still keep the operating rooms filled and the beds filled. And so, that's the antithesis to that is a program where we're trying to keep patients out of the hospital. So, there are big parts of the healthcare system, and in particular, I think the big integrated delivery systems and the specialists who work there who are pretty happy with a fee-for-service approach. They're very well paid, and many of the hospitals are doing relatively well. But slowly but surely, we're bankrupting the system, and we're not getting the same kinds of performance metrics that we were 30 years ago, 20 years ago. Our
Mm.
healthcare system on most metrics is deteriorating. So now, where we used to sort of lead the in more industrialized or developed countries in terms of our health outcomes, that's no longer the case. And in fact, it looks as though the healthcare system is deteriorating.
Right, interesting. Can I just say one more thing? And then, so I would also add to that. So, in terms of performance, that in this particular case is key. So, what would happen is because patients were frequently kind of cycling out, essentially because they weren't able to get sessions, I would potentially see people for maybe like 3 sessions, sort of sporadically. So, there was no continuity. So, whatever the effectiveness of therapy was, it essentially entailed the intake session. It entailed some sort of skills-based training, and then maybe a couple of follow-up sessions. And then at some point, people would sort of fall by the wayside, and they'd be like, this person doesn't have time or room for me or whatever. Right. So interestingly enough, on the one hand, even though technically the cycle of sort of patients coming in was persistent, that the clinic was obviously making money in terms of particular health outcomes, I would argue, at least compared to what I'm doing now, because I'm in private practice for myself, the health outcomes were pretty poor because there was no continuity. So I guess then the question would be is, which is going to kind of be a stupid question, but how do we get people to care about that?
Well, we talk about it and we point out the issues associated with it, and we look at the successes that can come with alternative approaches. The one of the main reasons to write this book was because there's really no solution out there for the American healthcare system other than a strong primary care foundation and a value-based approach. Nobody's got another alternative. It's not like somebody saying, the cardiologists or the orthopedic surgeons or the radiologists. That's the solution for our healthcare system. And it's really primary care. And people agree about that. And the National Academy of Sciences has put out two major reports, one in 1996, one in 2021. So, basically 25 years apart, saying exactly the same thing. But, they weren't convincing in some ways because they stayed at a policy level. And what I try to do with the book is I visited 40 or 50 different clinics and I try to bring it to a human level and demonstrate sort of how it works at that human level and how things are changing within the healthcare system itself.
Yeah. One thing that's very interesting, or maybe even alarming, is compared to the UK and Netherlands, the amount that the US invests in primary care is drastically lower. I think it's 12 to 15% of their goes to UK and Netherlands, and like 5% in the US. Um, why do you think that primary care has failed to get institutional power here?
Well, I think, in many ways, the primary care doctors lack sort of financial clout. And historically, what's happened is that more and more of them have been hired by hospitals. And so they become sort of employees there. And there's been advocacy for them, but I don't know if it's been sort of relatively effective. Your numbers are exactly right. We usually think of it 10 to 15% in many places in Europe. 3.5% in Medicare here, 4.5% in commercial insurance. So way under resourced in
Mhm.
terms of a well-functioning primary care system. And I think what we have to do is just continue to reiterate that the future does not look good. The demographics of the country are changing, they're worsening. We go over a 25-year period of time, we go from basically sort of 5 workers to retire for a retired individual to 2 workers for a retired individual. We're now beginning to sort of hit the really hard spot of that demographic curve. And as well, the government continues to sort of spend money that it doesn't have, so that it has huge budget deficits. And so the system of healthcare that we have is bankrupting things. It looks like it's going to get a lot worse. So sooner or later, there's going to have to be substantial policy decisions made. And I've said in the previous book on transformation of American health insurance that I don't see how employer-sponsored insurance can persist. There's simply no brakes on the inflation. Right now, if you're an employer, you're paying 3 times as much for most services as Medicare does, and that's going to go to 4 and then 5 times as much. So,
Yeesh.
how long before, that inequity in payment begins to become sort of unsustainable, and employers begin to go, why are we being stuck with these costs? I think that's coming. And when that comes, then that'll be the opportunity for substantial change in the way in which the healthcare system is organized.
No, yeah, and employers, I mean, at this point, are pretty much offloading some of the costs onto the employee. So I'm sure you know about this. So because I have patients who complained about this, and they would say, well, my portion of healthcare, the premiums that I pay is essentially way more than it was maybe a year ago. So that's what they're doing. They're just saying like, hey, we'll pay for some portion of it, but the rest of it you have to cover.
Right. But the employers can do that, but they are beginning to hit sort of rough spots associated with the changes the Affordable Care Act made in terms of sort of percentage of premium that they have to handle, and with regard to ERISA for their self-insurance status, with regard to how much out of pocket they can put on individuals related to their total pay. So those levers they're pulling for sure, and employers are trying to sort of leave their workers more and more underinsured, but there's limits to what they can do there. And the things that the insurance companies did for them, coding changes.
Hmm.
You get a certain kind of codes in as an insurer, and then you basically run them through a computer program, and then you recode them and you pay the people less. Well,
Wow.
that's just an artificial intelligence battle now
Hmm.
between the insurers and the providers, and the providers are going to win that. And the providers have all the leverage with regard to negotiations as well. Nobody likes prior authorization. It's hard to see how prior authorization persists in its current format. So the levers that an individual insurance company had to be able to sort of reduce costs for a commercially insured client are declining. And the ways in which you sort of off made your own workers pay more for their care, that's also coming to sort of a dead end, as it were. So the employers are really going to be facing substantial increases in the costs that they see over the course of the next decade. And that's why I say I don't think that can persist.
Yeah.
Mm. So something you said there that like I know this particular aspect is not discussed much in the book, but I just a very interesting thing that it caught my attention. So you mentioned prior authorizations for a moment there. So out of curiosity, how could that be changed from its current form? Like what would the alternative be to how that could be done?
Well, the insurers do prior authorization because they think there's a lot of care that's being done unnecessarily. That is, it
Right.
doesn't fit with the evidence base. So prior authorization basically haunts physicians when the insurance company thinks that this is not a recommended therapy. And having been on both sides of that, I ran sort of the relationship between a large integrated delivery system and the insurers, and then I was on the insurer side and ran the sort of prior authorization. I'd say that at least from my point of view, the insurers do a reasonable job of paying attention to the evidence base, and they're right that there's a lot of wasteful care, and most analyses of our healthcare system agree with that. That waste comes as a result of fee for service because you
Yes.
do things, you get
Yeah.
paid, and so doctors don't mean to do the wrong thing, but at the margin, these financial incentives affect sort of all of us. Now, the way you'd improve prior authorization is it's possible today, and the government's slowly sort of pushing towards this. But the insurers are saying, we don't see that this particular procedure is indicated. We don't see the clinical indications. And so they bother the doctor to sort of send over the clinical indications and make sure it looks like this is an appropriate thing. And so there's this back and forth, and it takes a lot of time, and everybody gets frustrated. It's possible today for all that to occur on an electronic round trip, where the insurers basically sort of interrogate the electronic medical record.
Hmm.
They use branching chain logic to decide whether or not a procedure should be done. And
Hmm.
then they develop the summary of what they found that they can send back to the physician. So prior authorization is something that should be able to take place in sort of the twinkling of an eye,
Wow.
and it should be based directly on the facts that exist in the electronic medical record. Physicians and hospitals have hesitated about giving insurance companies access like that. The insurance companies themselves have only slowly adopted the kind of technology that makes this sort of thing possible. But
Hmm.
we're moving incrementally in that direction. And in that regard, I think overall we could get to a situation where you could have really rapid decisions made around prior authorization. There's a lot of people who are concerned about that, concerns about artificial intelligence and how that might play a bad role, either on the side of more unnecessary care or more oversight by insurers. But
Hmm.
again, I think those kinds of things are tractable. So, I think the best answer for prior authorization, from my point of view, though, is go to a value-based approach. If I give the providers the money to take care of these patients, I back out of prior authorization completely. I don't even want to do. I won't do prior authorization anymore because it's now on the providers to make those decisions.
Wow.
And so I think you could get rid of prior authorizations completely if you went to a value-based approach, but interestingly, when a lot of doctors groups go to prospective payment, they employ the insurance company to do prior authorization to sort of help them out with it.
Oh, wow. Okay. Yeah. And then go ahead.
Sorry, no, I
Go,
just
go.
have to say that's awesome because honestly, having been on the side of, so I used to also be a medical assistant. This is way back in the day, and just having seen how many authorizations were rejected for not meeting medical necessity, and then the fact that okay, yes, of course, the doctor's then next step is to either appeal or provide more clinical documentation to support why it is medically necessary, which is fine. On the surface, that is correct. That's what you should do. However, uh, because that particular doctor was a fee for service based, type of that's their approach, they were seeing like 40 patients a day. And so the burden of how whatever percentage of those patients needing a follow-up on their authorization and then nothing being done for a while. I've seen that. I've seen delays in care just based on the back and forth that occurs in that process. So it's just nice to hear that, from a sort of a value-based approach, that kind of goes out of the window. That's kind of beautiful. I would that's cool to learn. So
Yeah.
yeah, yeah,
Yeah, and of course on the insurance company side, delay, bureaucratic, falderall associated with the prior authorization. That's the incentives that their financial incentives promote that. So the physicians are right. The physicians are doing unnecessary things because they get paid more, and then the insurance
true.
companies,
Yeah.
even for things that might be necessary, they'll take their time and hope that it sort of goes away.
Mm.
Wow. Yeah, and then when you talk about specialization, I mean that's something that also rings true for me as well because so in our field we're kind of pushed towards specializing just because again if you look at it from a business perspective, I mean if you're a generalist, there are God knows how many generalist practitioners, therapists, clinicians, whatever. So I guess the sort of question would be how do we kind of in terms of the value-based approach, right? So how does it sort of foster whether you're in medical school in any sort of area of the healthcare industry, how does it sort of foster sort of the desire or how does it make it more likely that somebody's going to get into more or be okay with being involved in more so general practice as opposed to being a specialist?
Well, I think in the value-based approach, you realize if you're running it, that the critical thing is going to be the sort of continuity and oversight, care, concern about your sickest patients, because it's your sickest patients that are driving the medical care costs. Sort of 10% of, usually we think 10% of people drive about 70 to 80% of the cost. So
Mm.
you want those individuals to have careful oversight, and you're going to pay for that. It'll return to you if you pay people to do that. So in many ways, people in value-based primary care, they earn more than some people in fee-for-service. And they certainly like their work a lot better because they can see that, what they're doing is really trying to sort of promote health, and they can take the time that's necessary to keep somebody out of the hospital. And that keeping somebody out of the hospital, that's a really good thing for me as a patient. I don't want to be in a hospital, and it's a
Hmm.
Mm.
really good thing for the group to reduce the number of unnecessary hospitalizations because that reduces overall costs and you earn profit on your capitated payment as a result of that.
Gotcha. So can you get into some of the interplay that will happen in a value-based system? So like what would that look like? So what's the coordination? Who is coordinating with each other? And what does sort of the day-to-day look like within it?
Yeah, the good practices that I saw, and you can sort of like, this is a sign or a symptom of a really good value-based practice. They start in the morning and they have a team huddle. and the entire team is there. So it includes their care managers, their pharmacists, nurse practitioners, nurses who are nurses assistants, and the physicians. They're all together in one room, and they're looking at the data associated with the way in which they've been taken. They've got certain specific sort of 10 to 12 key outcome measures that they're following, and they're looking how they're doing at that. And then they're talking about their sickest patients, and they're
Mhm.
talking about recent hospitalizations, and they're trying to sort of come up with strategies about how to prevent those hospitalizations. And they're all talking about sort of what steps can we take with regard to these three patients who look like they're very fragile right now. So, that's before you begin seeing patients at all. So that huddle, I think, is a sort of, if I see a huddle, I realize this is a strong value-based practice. And I saw that in private practices, in federally qualified health systems, in hospital groups. It occurs in a variety of different kinds of settings, but it's the sort of moniker you're looking for that suggests that this is a real value-based group. Then you're seeing your patients, and you've got a certain number of patients who are scheduled, but all of your patients who you've got responsibility for are so-called empaneled. That means they've
Mhm.
got a particular case manager and a particular doctor or nurse practitioner who is their person. And so you'll see these practices leave a reasonable number of slots unfilled during the day, like you were talking about, so that they can take walk-in patients, especially from those people who are really quite sick or who need additional care.
Mhm.
And their average visit time is going to be much longer. They may see 9 to 12 patients during a day. And they're not trying to sort of churn through because they realize if they churn through, they're going to miss important elements of care. And things are going to slip between through the cracks, and as a result, patients are unnecessarily going to end up in the emergency department or have worsening of their disease, or even end up in the hospital. So those are the kinds of things you look for, and when you see a well-functioning value-based practice, it really looks completely different than a fee-for-service. Even the sort of setting, in the places that are really sort of serious about it,
Mhm.
the team is in the center of a room and they're all working together. There's nobody isolated in an office somewhere. And then they're going out to visit the patients. And in fact, the most recent designs, which I saw in several different places that are really quite different, is the patients have one way to sort of go into the room, and the doctors and nurses have another. So
Mhm.
that room there, the egress that the doctors and nurses does takes them right back into this sort of central work area, and they call that sort of on stage and off stage. So it can be actually completely physically different in appearance than the fee for service, where you've got like a doctor sort of sitting in his office and the patients walk in and out.
Gotcha. So
Sorry, was that the same in the case of Dr. Best and Dr. Huber as well? That they both kind of have a similar sort of value-based approach, like in terms of the team coordination, in terms of how the office sort of looked, in terms of care managers, nurse practitioners.
They did, and I think what you're referring to is a couple of practitioners who I saw in Dallas, one in a totally impoverished area at a clinic that was run by Baylor Scott and White, which is a big integrated delivery system, but it was oriented towards taking care of the poor people who live in this area in South Dallas. And then Huber was up in North Dallas in a very wealthy suburb, and in a suburban mall. And so completely different patient population. But they both had these big teams, and they
Mhm.
were all coordinating with one another. So in that regard, both value-based and both very much oriented towards this kind of team model that we've been discussing.
Hmm. Interesting. So, I mean, I think somebody listening to this might even ask, well, why can't this work in the context of the fee for service model? Like, why can't it be that insurance companies end up paying out for longer sessions? So, what would you say?
Well, I mean, it could, but if you're incentivized to keep the patients healthy, and you are in a prospective payment approach, because if they stay healthy, they don't go in the hospital, overall costs drop, and I make more profit on the capitation. And that's as opposed to sort of a fee for service approach where, I might be paid to get sort of longer visits and things like that, but I don't really have the same sets of responsibilities. I don't have the same incentives to make sure
Mm.
the patient doesn't go in the hospital. The incentive is always going to be see the next patient, and just paying more on fee for service is not going to help with that.
Mm.
Now, there are people who say, and people who I respect, who've been at this game a lot longer than I have, at least with regard to sort of primary care policy, who say, like what we really have to concentrate on is getting the individual primary care doctors paid more for each
Mm.
visit. And I respect that. I just don't think without a value-based approach, I don't think it's comprehensive.
Interesting. Yeah. Because, I always wonder with insurance companies, how do they even make their assessments? So, like, I mean, Troy, I don't know how much you know about this or how much this is like a field or a part of your field of study. But, like, so for us with psychotherapy, I mean, there's essentially a shortage, if you want to call it that, of therapists, just because a lot of therapists don't take insurance. So it's not really much of a shortage because it's actually quite easy to find a therapist. That's actually kind of a misconception. Even when you look around the country, there's this sort of sense that, like, oh, therapy's hard to come by or whatever. That's actually not true for the most part. So what happens is because insurance companies pay probably like a third, maybe even a fourth to a fifth of what a therapist would charge out of pocket, well, out of network. So, and then what would happen is essentially a person would kind of be forced to sort of pay those prices if they wanted therapy. So I guess I wonder in your sort of understanding, right? How do insurance companies sort of, because this is sort of the problem also with fee for service, right? So like, let's say a person will come in for X amount for a particular session. I mean, technically speaking, from what we know about insurance, there's nothing really limiting that person. So I'll give you an example, like with psychiatry. So with psychiatry, you don't have to necessarily see a person for 15 minutes. There's kind of a sort of a framework there, meaning it's between like 50 and 30 minutes. But if you want, you could see them on the lower end. But obviously, many psychiatrists do. Whereas some, and people that I refer other people to, shout out to Jenny because she does this. She will see people for about 30 minutes, which is great. So, but my question really is that when you look at insurance companies, how do we sort of no, so two questions. Number one, how do insurance companies even make up their minds about how much to charge for a particular or how much to pay out for a particular service? And then also on the other end, sort of how do we begin to influence them in a way? Let's say if we were moving to this value-based system, how do we influence them to that system, meaning to get them to actually care about health outcomes?
Yeah, yeah. Well, the point you make about sort of behavioral health and psychiatry as a specific part of that is exactly right. I mean, it's just that for years, insurance companies have underpaid for behavioral health services, and as a result, you get upwards of 40, maybe 50% of payment for behavioral health is basically sort of out of pocket at this point. So that's a whole set of other problems. And there's also a lot of interest in these behavioral health models where it's a collaborative model between the primary care and behavioral health. And the good clinics that I saw, the good value-based clinics, they have a heavy presence of behavioral health and behavioral health experts who are there and ease of behavioral health referral because they realize that behavioral health problems play a big role with regard to most people who are chronically ill, and especially poor outcomes for those individuals. But I think, sort of the insurance companies are no more innovative than the hospitals are. And a lot of them will just sort of stick with what they've got, which is basically sort of fee for service payment. And the way they come up with the fee for service payment for primary care doctors is that they see what Medicare is paying and then they pay some percentage of Medicare. And for years, they paid just about or a little less than what Medicare did. Hospitals who hire primary care doctors have been able to use some of their leverage to boost the payments for those primary care doctors, but it hasn't made a big difference in terms of sort of the overall dynamics of the practice itself. It's still basically hamsters running on a wheel.
Right. So insurance companies are essentially mostly incentivized in some way to pay specialists.
Yeah, they are. They haven't bucked the system. Now, most insurance companies, and I'd say this is certainly true for, well, all the major insurance companies today. I'd say United Health, Humana, CVS, with Aetna, Elevance, and Cigna, the sort of big five corporate players. I'd say they all have moved in the direction of trying to sort of hire providers and set up clinics that are going to be more value based. When they set up a clinic, they don't do a fee for service clinic. They all
Mm.
do value based clinics. The Blues plans, which are smaller, regional, both mainly sort of state-based, they're beginning to do the same thing to some degree. And I
Mm.
see a lot of state regulation that's encouraging, especially practices that have a lot of Medicaid patients to move in the direction of sort of a value-based approach. So, the way the book is set up, I say, what can the federal government do? What can state governments do? What can big insurance companies do? What can regional insurance companies do? And then what does private equity do when they invest? And I see salutary circumstances associated with each of those things. And I'm hoping that the sort of combination of all those vectors is slowly moving us towards a value-based approach.
Can we get into some of them before?
Yeah,
Go
in
ahead.
regards to, let's say, Walmart, right, who exited their primary care sort of experiment in 2024, if I'm not mistaken. What do you think went wrong there versus, at least compared to something like Optum with United Health?
Yeah, I have the greatest respect for Walmart. I mean, if you're in the retail business, you can't help but be totally impressed by Walmart. And, we're working at CVS, you really had two big behemoths that were always worrying you. One was Amazon from one direction, and one was
Mm.
Walmart from the other direction. So I have the greatest respect for them as a corporation, but they never could figure out what they were doing in healthcare. They would, like every year or two, they'd get rid of everybody who they had and bring in a whole new crew, and they'd have a whole new strategy. The
Mm.
last strategy was basically we're going to dominate primary care. We're going to move to sort of 5,000 locations, and we're going to have these big primary care practices, and they're going to have audiology and podiatry and optometry and everything associated with it. And they began to sort of build that out, and then they backed out of it completely.
Wow.
I think the biggest problem that they had is that the people in Bentonville never figured out if you're going to do that, you really need to have control over the insurance part, or at least a strong sort of insurance company you're working with. So that really contrasts it with like Optum or Humana, and even to some extent CVS, where there's been an effort to sort of develop the practices themselves. And I think those companies have the same sort of view that I always had. I was a very strong advocate for years at CVS of doing vertical integration, which is
Mm.
basically, we own the insurance company, but we also own the delivery. So we look like a Kaiser Permanente model as a result of that. And so I think those big companies will stick at it. But the pure retailers, Walgreens is another example. They just never could understand sort of what they were trying to do with clinics. And I think that's what led to their big demise as well.
Mm.
Oh wow! And when it comes to insurance companies, would it be fair to say? I mean, maybe this is a bit reductive, but would it be fair to say that it really comes down to a short-term versus long-term perspective? Because if you think about it, I mean, in the short term, prospective care obviously doesn't make sense because the question is going to be like, why are we paying for relatively healthy or healthier people? And then obviously in the long run, the idea is like, well, if you do that now, obviously it'll prevent hospitalizations, it'll prevent rehospitalizations, it will prevent chronic and exacerbation of symptoms and chronic illness, further medications, etc. But fundamentally, I mean, I think the idea might be for insurance companies of is pretty much we're thinking about the next quarter. So really, my question is to say, would it be fair to sort of reduce it to that insurance companies don't necessarily think about long-term care because they don't think about long-term outcomes?
Well, I don't think that's true. And I'd
Mm.
say that the sort of facts suggest that's not the case. And there's no doubt when you're working for a corporation, you're staring at that quarterly call. You finish one, you got another one in 3 months. And everybody is oriented towards the stock price. But if you look at, they're not so admired today because there's a lot of questions about sort of fraud and lawsuits and federal government investigations and things like that associated with United. But if you look at what United did, they started almost 20 years ago on this pathway of hiring physicians and developing practices, and they stuck with it quarter after quarter after quarter. In some ways, it sort of paid off for them, and I think will continue to sort of pay off for them basically long term. So, at least from the point of view of sort of corporate visibility, it was a really admirable long term strategy they pursued. Humana has done the same thing. Humana really hasn't varied from a course of, we're going to do Medicare Advantage, we're going to do it well, we're going to own clinics, and they continue to sort of persist in that direction. And it's totally different than what Walgreens and Walmart have done, where they basically sort of jump into a flash in the pan and then jump back out again.
Mm. So interestingly, I guess what route do you think? I mean, maybe this isn't an either or question, but what route do you think would be at this stage of where we are as a country politically? What do you think would be more helpful? Sort of attempting to somehow incentivize capital and venture capitalists to invest, or do you think it would be sort of more state-sponsored funding?
I think it's got to be both. I mean, that's an
Mm.
easy answer, obviously, and
Yeah.
I don't want to avoid it. But I do think that venture capital, venture capital is bad in some places. Like we saw venture capital firm, private equity, take over a bunch of very impoverished Catholic hospitals in Massachusetts, which became sort of Steward Healthcare. You had to be a fool if you didn't say, sort of looking at that, that was going to turn into a disaster, and it did. But the state government and the federal government sort of allowed for it to happen. And there's a lot of bad things that private equity does around sort of nursing homes, ownership of hospitals. They even aggregate, dermatologists and gastroenterologists and try to basically negotiate for higher fee for service
Mm.
reimbursements as a result of leverage they build up in individual marketplaces. So there's a lot of bad stuff that goes on, but at least with regard to primary care, they realize what they have to do is support primary care practices to be able to provide long-term continuity care for individuals and reduce costs as a result of that sort of better care. And so I see the private equity investments in primary care as something that's very beneficial.
Mm.
And we used Aledade as an example, but there are many others. Very interesting, for instance, what Oak Street is doing,
Mm.
and the care models they develop, especially for very sick patients with Medicaid. So I think they're important, but yeah, it has to be comprehensive, and the states can help make it comprehensive. If you look at the states that are really trying to sort of control their healthcare system, Massachusetts to some extent, I think Rhode Island and Vermont have the appropriate sort of impulses, but Oregon's probably the best example, at least of the ones I looked at.
Mm.
What you see is a very comprehensive approach where you've got to push towards value-based care. You've got concerns about sort of hospital costs. You've got efforts to improve access to care, even for those who don't qualify for Medicaid. So,
Mm.
you have to be impressed by that. But I would hope that all these things sort of coming together are going to help get us towards a value-based primary care base for the foundation for the healthcare system.
Mm.
Gotcha. Yeah, and I think the thing that I hate the most about fee for service, which I'm assuming a lot of clinicians just across the board would agree with, is the fact that because it's a business model, we have to essentially brand ourselves. So I don't, nobody went to school, whether me with graduate school or doctors in medical school, nobody goes there to brand themselves. Like, how the fuck do you end up doing that? And so it's something that we kind of have to learn along the way. And it's not really great. So if you, let's say, look at psychology today, a lot of times you'll have therapists sort of over branding in the sense of pretty much claiming to be experts in too many things where the idea is you probably cannot be an expert in all of these things, meaning you can't probably specialize in various personality disorders as well as a bunch of axis 1 disorders. It's just not possible. You cannot be an expert in all those things. So with that being said, I think the thing that for all of us that we pretty much hate about fee for service is the hyper competitiveness and the high level of competition involved, because if the thinking is that we kind of go to school to sort of to serve the public in some ways and to help people, and the hope is that sort of people kind of come to us because this is what they're actually looking for, as opposed to us in some ways sort of maneuvering and manipulating and advertising. I think the thinking is that for a lot of us in this, in learning these different systems, I think a lot of us would prefer a value-based system just because of the fact that we don't want to compete, number one, and we don't want to have to learn how to become influencers and business types. This is not what we go to school for.
Yeah, I think you're exactly right. And many of the people in value-based care, the thing you hear sort of repeatedly is, this is why I went to medical school. This is really what I wanted to do. I wanted to take care of patients. I wanted to have long-term relationships with them. I wanted to be able to help them, and I wanted to have time to do so. And so, in that way, it was almost unanimous across the board in the value-based practices I talked to. The doctors were much happier.
I got you, man. So, Troy, I'm curious, where do you see this going? So, in terms of where we are in this trajectory, so what are the next steps, and essentially, what do you feel about the public perception of all of this now?
Well, I think really you got sort of two paths. One is that we just continue on a sort of fee for service approach, and things continue to worsen. Our health statistics continue to look worse. The government, unfortunately, this new administration is reversing what was a sort of 20 to 30 year impulse towards greater access to healthcare. You begin to cut healthcare back, and so it becomes a sort of two-tier or three-tier system with very poor care for those who cannot afford it. I'm hoping it doesn't go that way. What I'm hoping is that, we get past this administration, the next administration comes in and says, the original Affordable Care Act approach was the right approach. We need to have people have access to healthcare. And the government slowly but surely begins to sort of play a larger role as the employers realize they can't handle the costs associated with healthcare.
Mm.
And at the same time, primary care is value-based, is growing and becomes that real foundation that we need. So, what I'd like to see is a system that'd be similar to sort of the Netherlands or something like that, where you've got, sort of 15% of your dollars going into primary care. Everybody has a primary care doctor or nurse practitioner, and that individual is intimately concerned with their welfare. Now, you're a healthy person. You don't need to have that many visits with your primary care provider, but you're a sick person. You want a close and intimate relationship with that individual so they can help you get through this ever more complicated system.
Mm. Yeah, and since you mentioned Medicare for all, so a question I would have for you, because this is something I've heard multiple times. So I think that we have, and to be fair, I'm not citing everybody here or even close to it, but there are certainly doctors who feel this way. So they would say something like, "Look, I love Medicare for all as an idea. I love, and I have went to school, obviously, and I did go to school to help patients, and the point is to be, of service to people. However, the idea is, well, medical school costs are, exponentially high. So the idea is a lot of these people are in a significant debt. So what would you essentially say to a provider who says, like, look, maybe let's say a Medicare for all could work, or maybe this value-based approach could work. Maybe it could work for me somewhere down the line, maybe 20, 30 years or whatever. But at this point, I need to make it work with fee for service because I have all of this debt and, let's say things to provide for with family, lifestyle, etc."
Yeah. Well, I'd say if you're primary care, the primary care practices are very value-based, whether it be small ones like ChenMed or larger ones like Optum. Pay is better.
Mm,
Same thing with Kaiser Permanente. So, if you've got medical school costs, then you're going to be able to. Now, you're still not going to make as much as an ophthalmologist or a dermatologist today, but hopefully we can change that so that there's relatively sort of equal payment or more equal payment between specialists and generalists in the healthcare system. That's pretty true in Europe, where the differences in the amount that the individual specialists make is quite a bit more telescope than it is here. So that's one thing I'd say. And then there's a lot of other things you could sort of like, for instance, costs in medical school. You don't need 4 years of medical school. You just don't. Fourth year of medical school, you're basically sort of applying for residency. So that
mm,
could, there's like common sense steps that we could take, and we'll be forced to take, I believe, because the people as I hit sort of 85, there's going to be relatively few working young people to provide enough additional sort of surplus from their labor that allows me to get my medical care. So we can't afford this unconstrained medical care that we have today. So we're going to have to take these steps. The government will have to. You can avoid things for 3 or 4 years, like you can avoid being concerned about global warming for 3 or 4 years, but it's not going to go away. Somebody's
Right.
going to have to address it sort of sooner or later. And that's the way it is with the healthcare system.
gotcha. But you're ultimately saying, I mean, we would have to influence insurance companies and obviously the medical schools as well. So, meaning whatever it was that sort of, let's say, exponentially increased the cost of medical schools, something is going to have to in turn reverse that to whatever degree.
Yeah, exactly right. Yeah.
Okay. Okay.
And I should ask this. I mean, I think I know the answer to this question, but I'll humor you. So if you could advise policymakers to take one concrete action right now to strengthen primary care, what would it be? And if it is that 10 to 15% investment, all right, fair enough. That's what I think you're going to say, but maybe it's something else. Yeah,
Well, I'd say more importantly is a shift towards a value-based approach in payment for the entire healthcare system.
I see.
And part of that then will be greater payment for the generalists and primary care providers, nurse practitioners, physician associates, and primary care doctors will be sort of part of that. But I would say the most important thing is to sort of continue the emphasis on value-based care, which has been a big part of what CMS and CMMI have been doing over the course of the last decade.
Mm.
Okay, I love that. All right, so Alan, before we wrap up, final questions for Troy.
Yes, if we wanted to follow you, follow your work, and of course buy the book, where can we do that?
Well, the book's available wherever you buy books, obviously, sort of on Amazon or from the Johns Hopkins Press directly.
Mhm.
And I'm maintaining a pretty active role on LinkedIn. Continue to sort of offer my opinions there about a variety of things and things that I try to bring forward, other things I publish in the health policy literature there.
I
Mm.
love it. Troy, thank you so much for coming
This
on.
was
But not
awesome.
not only was this incredibly insightful, on top of that, we both probably want to add is that your work is incredibly meaningful, which is why we wanted to have you on in the first place.
Absolutely.
Well, thank you very much. That's awfully nice of you. It's great meeting you.
You as
Absolutely.
well.
We'll talk to you soon.
Take care.
Okay, bye-bye.
All right. That was good. All right. So, everyone, of course, as you know, you can always follow us at Seize the Moment Podcast on Facebook and on Instagram. On X, we're at Seize_podcast. Like, subscribe,
Hit the
hit the
bell
bell
on
on
YouTube.
YouTube. And again, thank you so much for watching. See you next time.